Okay, this is chapter 20 of the ATI Mental Health, Somatic System, and Related Disorders. Clients who have somatic system and related disorders are often encountered in primary care settings. It is important that the nurses are familiar with these disorders, as well as their role when caring for these clients. Somatic symptom disorder. Somatization is the expression of psychological stress through physical manifestations. The physical manifestations of somatic symptom disorder cannot be explained by underlying pathology. Somatic manifestations can cause distress for clients and often lead to long-term use of healthcare services. Manifestations can be vague or exaggerated. The course of the disease can be acute but is often chronic, with periods of remission and exacerbation. Clients who have somatic symptom disorder spend a significant amount of time worrying about their physical manifestations to the point where it assumes a central role in the client's life and relationships. Clients often reject a psychological diagnosis as the cause for their physical manifestations. They seek care from several providers, increasing medical costs. Clients are usually seen initially in a primary or medical care setting rather than a mental health setting. Anxiety and depression are often comorbidities. Risk factors. First degree relative to who has somatic symptom disorder, decreased levels of neurotransmitters, serotonin, and endorphins, adverse childhood experience, learned helplessness, expected findings. Somatic manifestations that disrupt the client's daily life, excessive preoccupation with somatic manifestations, remissions and exacerbations of somatic manifestations, high utilization of self-services and multiple healthcare providers. Laboratory tests. Lab and diagnostic tests, or CTs and MRIs, can be performed to rule out underlying pathology. Patient Question Health Questionnaire, PHQ 15, used to identify the presence of the 15 most commonly reported somatic manifestations: abdominal pain, back pain, pain in extremities, chest pain, dizziness, etc. Nursing care. Accept somatic manifestations as being real to the client. Assess for suicidal ideations and thoughts of self-harm. Identify secondary gains from somatic manifestations like attention, distraction from personal obligations or problems. Encourage verbalization of feelings. Encourage daily physical exercise. Reattribution treatment. Work with the provider to provide reattribution treatment, which assists clients to identify the link between physical manifestations and psychological factors while promoting a sense of caring and understanding. 4 stages of reattribution treatment include Stage 1, feeling understood. These therapeutic communication, active listening, and empathy to obtain a thorough history of manifestations while focusing on the client's perception of the manifestations and their cause. This stage also includes a brief physical assessment. Stage 2, broadening the agenda. Provide acknowledgement of the client's concerns and provide feedback about assessment findings. Stage 3, making the link. Use therapeutic communication to acknowledge the lack of physical cause for the manifestations while allowing the client to maintain self-esteem. Stage 4, negotiating further treatment. Work with the provider and client to develop a treatment plan that allows for regular follow-up visits. Medications, analgesics, antidepressants, and anxiolytics. Patient education. Assist a case manager to develop a follow-up appointment schedule with provider every 4 to 6 weeks. This strategy provides set appointments and decreases the need for unscheduled health care, as well as medical costs associated with laboratory and diagnostic tests, if treatment from other providers is preferred. Illness anxiety disorder. Misinterprets physical manifestations as evidence of a serious disease process. Illness anxiety disorder, previously known as hypochondriasis, can lead to obsessive thoughts and fears about illness. Clients research their suspected disease excessively and examine themselves repeatedly, such as examining throat in the mirror. Clients continue to have anxiety despite negative diagnostic tests and reinsurance from the provider. Risk factors. First degree relative who has illness anxiety disorder, childhood trauma, depressive disorder or anxiety disorder, low self-esteem, or major life stressor. Expected findings. Excessive anxiety that a serious illness is present or will be acquired. This anxiety is present for more than 6 months through the acute actual illness the client fears can change. Preoccupation with performance of behaviors that are health-related, performing a daily breast exam due to the fear of breast cancer. Some clients have illness, anxiety disorder that is the health-seeking type, frequently seeking medical care and diagnostic tests, while others exhibit the care-avoidant type, avoids all contact with providers due to the correlation with increased levels of anxiety. Functional neurologic symptom disorder. Functional neurologic symptom disorder, previously known as conversion disorder, results when a client exhibits neurologic manifestations in the absence of a neurologic diagnosis. Clients who have functional neurologic symptom disorder transmit emotional or psychological stressors into a physical manifestations. Neurologic manifestations can cause extreme anxiety and distress in some clients, while others can exhibit a lack of emotional concern. The neurologic manifestation causes a significant impairment in multiple aspects of the client's life, and clients who have functional neurological symptom disorder have deficits in voluntary motor or sensory function. Expected findings. Manifestations of an alteration in voluntary motor or sensory function. Motor, paralysis, movement, gait disorders, seizure-like movements. Sensory, blindness, inability to speak, which is aphonia, inability to smell, which is anosmia, numbness, deafness, tingling, burning sensation. Clients who have extreme desire to become pregnant can manifest a false pregnancy, which is pseudocyesis. Psychological factors affecting other medical conditions. Psychological and behavioral factors can play a role in any medical condition. The mind-body connection has been subject of research, providing a link between clients' psychological state and their physical condition. The development of certain medical conditions has been linked to clients who have depressive or anxiety disorders, and other medical conditions have been found to be caused by or perpetuated by a psychological or behavioral factor. Expected findings. A confirmed medical diagnosis, a psychological or behavioral factor that is linked to the medical diagnosis in one of the following ways: contributes to the development, interferes with the client's adherence to the treatment, places the client at increased risk for physical health problems, or causes or exacerbates physical manifestations. Patient-centered care. Discuss the client's physical exam findings, assess for suicidal ideations and thoughts for self-harm. Factitious disorder. A factitious disorder, previously known as Munchausen syndrome, is a conscious decision by the client to report physical or physiological manifestations. The falsification of manifestations is done in the absence of personal gain by the client other than possible fulfillment of an emotional need for attention. In some cases, clients inflict self-injury. Factitious disorder imposed on another is present when the client deliberately causes injury or illness to a vulnerable person. This is Munchausen by proxy. Clients often have an average or above average IQ. The client often reports new manifestations following negative test results. Risk factors is history of emotional or physical distress, impaired neurologic ability for information processing. Expected findings: report or false physical and physiological manifestations, possible evidence of self-injury. Patient-centered care: perform a self-assessment prior to care. Communicate openly with the healthcare team any suspicions of factitious disorder or factious disorder imposed on another. This action can help reduce medical costs and possible unnecessary treatments and surgical procedures.